Thank you, everybody. Happy Friday and welcome to this week's Intermountain Healthcare COVID Community Update. I'm Jess Gomez from Intermountain Healthcare and pleased to be joined with Dr. Eddie Stenehjem from Intermountain Healthcare Infectious Diseases. Eddie, thank you for joining us this morning.
Happy to be here, Jess.
We got a lot to cover. You've been off for a few weeks, and I know you've been very, very busy, so there's a lot to go through. We would ask the journalists who are joining us, please submit your questions on the chat, and we will ensure that those questions get answered. And happy to run through any questions and other information that you need. Eddie, let's start with kind of where we're at. The data from the Department of Health from yesterday, again, shows a fairly healthy clip of new coronavirus cases in the state, 1,805 new cases. 418 of those cases were in school-age children from K through 12. We had another, let's see here, total of 2,983 deaths total from in the state of Utah. So we're nearing the 3,000 mark on that. And we also had another healthy clip of hospitalizations that we're continuing to see. Let's talk a little bit about what you're seeing in the ICUs and in the acute care units within the Intermountain healthcare system.
Yeah, within Intermountain right now, as of this morning, our capacity in the COVID hubs, so those hospitals that are main COVID centers, Utah Valley, McKay, Intermountain Medical Center, et cetera, we're at 99% occupancy with around 45% of those patients being COVID-19 patients. We're at 98% occupancy across all ICUs across the enterprise. And so we are at a level where we've been. And we've been here now for a number of weeks. We haven't really seen a decline in any of our capacity issues. And so we're just remaining at 100% essentially. So we continue to be full, and what's driving that is the COVID-19 cases. When we look across our community, at the beginning of this week, we were hoping to see a continued decline of cases. That's kind of where the epi curves were pointing us. But then the data from yesterday and the day before really shows that we're at a high plateau. And so cases now across the state have plateaued. And so I anticipate that we'll probably continue to see this level of occupancy in our hospitals for at least a couple of weeks. And that's assuming that cases start to trend down in the next week or so. And so we're still in the thick of it, and we anticipate to be at these capacities now for probably another 2 to 4 weeks.
Yeah. Yesterday, the Department of Health reported that the state's referral centers, those 16 hospitals that are most equipped and best resourced to deal with and treat COVID patients, were over 100% capacity. I know that number fluctuates. How are the hospitals doing it? What are we doing for this duration of time to hover at or exceed that 100% capacity? What are we doing to be able to withstand that threshold?
Yeah, I mean, we're doing a lot of things within the hospital. I mean, one thing that's gotten a lot of attention is that we've had to turn off non-urgent surgeries. Many surgeries, think, complex vascular surgeries, heart surgeries, they need ICU beds after their surgery. It's just the way that they recover. And because of our capacity issues, we can no longer offer those surgeries because we can't provide the care, the safe, effective care that those patients need post-operatively. We just don't have the room to provide that. And so, yes, these are non-emergent surgeries, but these aren't elective surgeries by no means. I mean, people that are having strokes due to, clot in their arteries, or they have blockages in their heart, they need those surgeries. But we unfortunately just can't offer them at this time because there's no way to care for them, post-operatively. So it's just one example of what we're doing. We're also doing a lot of load leveling. And so, if somebody comes into one hospital and there's no, bed or ICU bed available there, we may have to, ship them to another hospital. We're collaborating with our other healthcare partners to make sure that that we're all full and that we're not, putting all patients in one hospital or another. And then, we also have to deny transfer requests from out of state. Intermountain, University of Utah, other hospitals in the state are places where people will send patients when they need higher levels of care. And typically Intermountain accepts those with open arms. And at this point, we're unable to, assist our partners in neighboring states to be able to accept those patients. And lastly, we're, making plans of, what will happen. What do we need to do to staff ICUs and staff hospital floors in case the numbers go up? And, what are our contingency plans for that? So a lot of action going on across Intermountain Healthcare, all focused on being able to provide the care that we want to be able to provide to our patients with COVID-19 and also with non-COVID-19 illnesses.
Yeah, you've been doing this for a long time. And I would imagine this is probably the longest duration where we've been at that capacity level or exceeding that capacity level. Those numbers fluctuate. Describe what it's like to, have to do this day in and day out in terms of the high numbers. Obviously there's days where we peak and we go up and down, but this is a fairly sustained threshold of capacity volume due to the COVID surge. What is that like as a clinician to just have to day in, day out for this prolonged period to be able to keep up with that high volume and the demand that exists right now?
Yeah, first of all, I think to say like the true clinician heroes are the ones that are in the ICU and the ones that are on the medical floors that are caring for these patients day in, day out, that are going the extra mile and, talking to family members through iPads and trying to communicate through, face masks and face shields and PAPRs. And, those are the people that are putting in that work day in and day out. And you're right, it's been sustained now for quite some time, probably longer or equivalent to what we dealt with, back in November, December, January, when we had that initial really significant surge. And so now this is the second time that our caregivers are asked to do this. And our caregivers are getting very good at caring for COVID patients, and they're getting very accustomed to it. But it's really sad to see, illness like this that in many cases can be prevented. And so it is challenging to come in and do this every day, have these same conversations with patients every day, knowing that some of it is preventable. We'll continue to care for those that are vaccinated or unvaccinated, but it's just sad for us to be able to have to see that all the time. And I think people are nervous about, what's going to happen as we roll into the winter months. Back in, January, we had this hope of like, okay, vaccines are rolling out. Shortly thereafter, we're going into summer. Now it's just this concern of we're headed into, just the kind of cold, dark winter. And, we just hope that we can get past this and move through this and get to more of a steady state before we're in the thick of the holiday season.
Yeah. Nationally, we're hearing that perhaps cases may have plateaued. In Utah, where do we stand? And there's a couple of questions from some reporters asking, where are we now in terms of total cases, in terms of what we think is going to happen? Add a little bit more to what you talked about in the coming months in terms of based on what we saw last year, what are your concerns and what are your thoughts about heading into the next coming winter months?
Yeah, so when we look at kind of where we're at in Utah, we had this pretty quick rapid onset of Delta cases. And then we haven't had that quick decrease that was seen in some other states, Florida and Alabama and some of those southeastern states that had this really quick rise and then quick drop off of Delta. We haven't seen that yet in Utah. We've had this quick rise and now we're at this plateau. And we hope what we'll see is that will decline off of that plateau really, in the next couple weeks. The difference, though, is that our plateau hit right when kids are going back to school, whereas the high peaks in the Southeast occurred more in the summer. And so I think there's some complicating issues there in terms of trying to really understand the epidemiology of it. I think the other challenge that we have with trying to assess the epidemiology right now is that our market has a lot of home COVID tests. And this is a good thing. By no means do I think this is a bad thing. This allows patients, our community members to test at home and determine if you're positive or negative. But those tests don't come into the state. And so we don't have any eyes on those positive tests. And so we really don't know what is the impact of all of those positive tests in our community, or those home tests in our communities that we're not counting in our numbers. And so that's a kind of a big question mark for us as well. So at that point, you turn more to these kind of stable measures that are reflective of community transmission. So hospitalization is a really good one to look at. And then also ED visits, primary care visits for COVID-like illness is also another really important tool for us. And we've seen the ED visits for COVID-like illness have decreased a bit over the past a couple weeks. So that's a very good sign that this may be waning through the community. And then what we'd like to see is that the hospitalizations follow. And that would be also another really good sign that the community transmission is lessening. So really, as we go into the winter, those are the metrics we're going to be watching really closely. Now, the question is going to be, well, do we expect another surge in the winter, especially over the holiday season? That's a tough one to predict. That being said, the difference between this year and last year is that this year we have well over 50% of our community members are fully vaccinated. And so that takes out half of the population for that are no longer really high risk for severe disease. And there is a component of natural immunity in those that have been infected previously with either the Alpha variant, the Delta variant, or the original strain. And so the amount of people in our community that are susceptible to severe disease is much less this winter compared to last winter. And that's something that's in our advantage. And so I don't think we anticipate really big surges over the winter. That being said, I said that this summer, and look where we are. And so we clearly don't always have this right. But I do think that the vaccines show really good effectiveness against the Delta variant. We know that a lot of people have been infected as well, which does pose some protection, likely not as good as the vaccine, but some protection. And so that may be enough to really decrease our cases and keep them at a low plateau moving through the winter. COVID-19 is going to be with us through the winter, and it's going to be with us through next year. So I don't anticipate this going away, but I do anticipate that the cases hopefully will remain lower and a low plateau, something that's a little more manageable for us in the healthcare systems.
Yeah, as we talk about kind of the demands and the pressures on the health system, there's a couple of questions pertaining to that. For people who need immediate life-saving care, heart attack patients, stroke patients, again, we've talked about how this impacts the overall community. It's not just the vaccinated, it's not just the unvaccinated. Really, we are impacted in terms of our ability to treat everyone. Talk a little bit about what it means for those patients who need that life-saving care. And I think we probably want to be clear that they need to come to the hospital. We're gonna take care of them. But what does that look like to you these days with high volumes in terms of also making sure that patients who need life-saving care receive that?
Yeah, absolutely. I mean, we can't understate that. If you have signs and symptoms of a severe condition, chest pain, signs of stroke, absolutely come to the hospital. We will find room. We will give that care to you. So what does that look like in the hospital is a couple things. So one is there is a big push to move people from the ICU to the medical floor. And so we use certain criteria to ensure stability of patients, to ensure that they are safe to be moved from the ICU. So those intensive care units where we have closer nursing monitoring, more invasive monitoring of our patients, over to the standard medical or surgical floor, which is a step down in the intensity of care that we provide patients. And so one of the things that we see is that we need to move patients from the ICU to the floor quicker. And so they may not be as stable. They may not be as ready to move to the medical floor or surgical floor, but we just need to do it to be able to open up a bed. And so if we need a bed, we try to move patients that can be moved from the ICU to the floor. And, now you're dealing with taking care of sicker patients on the medical floor. And those patients, our nurses and our staff are not used to care for those sick of patients on the floor. And so that's one difference. And then the other difference is that we're, really asking nurses and respiratory therapists and pharmacists and physicians to take care of more patients than they're used to in the ICU. And so instead of caring for 12, 13 patients, a physician may have 15, 16, 18 patients. And so we're just stretching our healthcare resources thinner. And then we're moving patients to units that the staff there may not be as comfortable taking care of. That being said, we'll make room. We'll find a place for you to be able to provide care. And it is absolutely important that you come to the hospital, come to the ED, go to see your primary care doc if you're having symptoms of life-threatening illness.
Yeah. A question about kind of the resurgence of some of the other viruses, respiratory issues that we typically see in the fall and winter. Last year we had a mask mandate off and on, and this year we don't. And so the question is, with less people wearing masks, what are we concerned about in terms of the other respiratory issues that may arise that may not have the same protection with as many people wearing masks in the community?
Yeah, last winter was a lot more straightforward from a diagnostic standpoint, and I say that because of the universal masking, because of more of a focus on social distancing, not having large events, congregate events, because of those things, we really didn't see any other respiratory viruses. And so what I mean by respiratory viruses, I think about things like RSV, influenza, rhinoviruses, all those viruses that also cause the common cold. We just didn't see any of those. And so when somebody presented to an ED, to an urgent care, to the hospital, and they had respiratory symptoms, that was COVID until proven otherwise. We had to make sure it wasn't bacterial pneumonia, but typically that was going to be COVID. Now, as people are presenting, we're seeing more and more other respiratory viruses, and particularly RSV. And so we're seeing a very odd spike of RSV cases in kids right now. We didn't see any RSV really last winter, but now we're in the midst of this pretty significant spike of RSV. And honestly, we don't know what that's going to look like moving through the winter. Influenza is another one that we're just going to have to wait and see. Again, last year we didn't see any influenza because of all the things we mentioned, and because of travel bans and people not traveling from the southern hemisphere to the northern hemisphere, which definitely brings in influenza in our community. Now that people are traveling again, now that we're not wearing masks, I suspect we're going to see influenza. To what extent? Hard to say. But I do think that we're absolutely going to see influenza this year. And what strains of influenza we'll see is really kind of anybody's guess, because we just don't have that history of what happened in the southern hemisphere to really base our vaccines on. So it is really important to get vaccinated for influenza. Now, the other challenge is diagnostics in things like in the urgent care in the ED, because as more and more things are circulating, it's really important for us to make the appropriate diagnosis. If you come in and have influenza and are high risk, we need to get you a drug called Tamiflu. If you come in and you're high risk and you've got coronavirus or COVID-19, we need to get you set up for monoclonal antibodies. And so it's really important for us to be able to make that diagnosis, which is going to be a little more challenging this year as compared to last year.
Yes. Let's switch gears a little bit to the booster doses. What should the public know about all the information about the availability of booster doses now?
Yeah, the whole science of booster doses is just in flux, and it's going to change. And so first of all, I would say, just get ready. There's more information to come. FDA will be hearing from Moderna and J&J later this month in reviewing their data on boosting. We have the data from Pfizer, which is now under EUA approval. And so this is going to be an area that we're going to continue to talk about and continue to provide guidance. So as of right now, what the data is on boosting, we know that the Pfizer vaccine, when you get out to month 6, and really it starts around month 4, you start to see waning of the effectiveness of the vaccine. Not huge waning, but we do see vaccine effectiveness, where it was around 94%, coming down to more like 80%, and in some cases in the high 70s as well. So we do see evidence of waning. Now, to prevent that waning, you can give a booster shot. given a shot 6 months after that second dose will increase your antibody levels and increase your protection. And that's what's available right now. So for individuals that have received a Pfizer vaccine and are 6 months out from their second dose, boosters are available for anybody age 65 or greater. And then we also recommend that people between ages of 50 and 64 that have complicating medical conditions like diabetes or obesity, those people should also get a booster as well, and that's a strong recommendation. And those that are between the ages of 18 and 49 that also have those complicated medical conditions, they can consider getting a booster as well. It's not as strong of a recommendation, but they are available to those individuals. Now, the last group that have boosters available to them are those that, by nature of their occupation or where they reside, are at high risk of getting COVID-19. So that includes healthcare workers, that includes teachers, grocery store workers, et cetera. So that's the groups that are available for boosters right now. And again, it's only for Pfizer recipients, and they need to be 6 months out from their second dose. And we do recommend people get that. We're seeing a very natural experience in Israel right now and the impact of boosters in their country. And what we've seen is that once a booster shot has been initiated, that group appears to have better protection. So that vaccine effectiveness goes back up into that higher range again. And so we are seeing evidence that boosting works. We also have seen evidence that boosting is safe. And so it is at this point, if you fall into one of those categories, we definitely do recommend to go ahead and get a booster shot.
You were involved in a national study that looked at COVID vaccinations. In particular, it was published in the New England Journal of Medicine. For those people who still have questions, concerns about the vaccine, again, we advise they talk to their healthcare provider. But with your work in this area, what information do you have to offer in terms of what you know about the vaccinations that are currently available in the United States?
Right, and so we're part of a national group that's studying the effectiveness of these vaccines over time, and so we published a paper just here in September that really looked at how effective is this vaccine, looking at both the Pfizer, the Moderna, and the J&J vaccine at preventing hospitalizations, at preventing ED visits and urgent care visits. And the nature of this study was a really big study because we were able to harness the power of our electronic health record throughout 7 networks of healthcare systems. So it was a network of networks. And so we had over 187 hospitals. And so the data we were able to obtain was just enormous. And that study showed that, and the data went through June of this year, the study showed that the vaccine was incredibly effective at preventing EDs, urgent cares, and hospitalizations across all ages, across all ethnicities and races, and across all medical comorbid conditions. And so it really highlighted the impact and the highly effective nature of these vaccines. Now, we followed up that study with another evaluation that was published in the MMWR that looked at specifically the vaccine effectiveness during June, July, and August, the time when Delta variant was the predominant virus. And what we saw was that Moderna remained very, very effective in reducing hospitalizations at 91%, but we saw a bit of a drop-off for Pfizer at 80% and an even more drop-off for J&J. Now, that drop-off, is that due to the Delta variant or is it due to waning? We're unable to make that determination in our data, but it just definitely reinforces the need for boosters, especially those in Pfizer and in Moderna. And, I think what we can say right now is that our knowledge of these vaccines is much, much different now than it was 6 months ago. And so 6 months ago, people were rightfully hesitant. They were saying, hey, there's only been a couple studies on this, even though that they had 40,000 people in each study. I want to wait for more data. We have more data. Right now, I would say that the COVID-19 vaccines are the best studied vaccine that we have in the world. The amount of data, the amount of study, the amount of intensity of the study on these vaccines has been just incredible over the past 6 months. And now we have just an enormous amount of data that really is able to show us the effectiveness of this vaccine and the safety of the vaccine. And when we think about vaccine safety, the side effects of vaccines occur within 2 to 3 months of getting that vaccine. And so we are now well out. We're at about 10 months of follow-up. And so we are going to have identified those effects due to the vaccine by now. And so we have a very good handle on the safety profile of the vaccines. And quite frankly, the systems have worked, right? We've identified the clotting issues. We've identified the myocarditis. These are incredibly rare events that we've been able to identify because of these surveillance systems. And so at this point, now in October of 2021, the amount of knowledge we have on these vaccines is just incredible. And so we're very confident in saying that these vaccines are safe and that they're also very effective. And that's a very different place than we were just 6 months ago. And so I think it's time for those people that were hesitant because they wanted more knowledge. We have more knowledge right now, and I'd say talk to your healthcare professional about that because we have just an incredible amount of data on safety and efficacy that supports the vaccination.
One last question, then we'll let you go. We know how busy you are. Pfizer has applied for approval for vaccines for children 5 through 11. How important is it to get that group vaccinated and protected?
Yeah, this is incredibly exciting to see that the FDA will be evaluating the application for Pfizer for ages 5 to 11 on October 26th. I'm assuming then shortly thereafter, ACIP will review it as well and make a determination for CDC. This is just great news. This is really, really great news. This covers those individuals, those children that are in school. We know school is a congregate setting. We want to make sure that our children can be in school and be in school safely. That is our goal, to make sure that we can have that happen on a consistent basis and not have kids come in and come out and have to test all the time. And so the more we can get people vaccinated in that age group, the more safe that becomes. And so this is going to be a game changer for us, and we're really excited to be able to offer this to our children.
Well, Eddie, thank you so much. Thank you to you and all your colleagues who are on the front lines during this surge. We appreciate you. We appreciate you taking time out to join us and update us today. For those who have joined us, we'll send out a recording of today's discussion with Dr. Stenehjem, and we'll include some B-roll, updated B-roll that we have for you from our intensive care units. Eddie, we hope you have a nice weekend. Thank you so much. And again, appreciate all that you do.